Okay, all set.
Uh, well, good morning, everyone. My name is Xu Chao. I'm from China, and I'm a doctor from the Zhejiang Provincial People's Hospital. Today, I will. This is my topic of my presentation. This is a research during my doctorate period. My title is Metallic Hyperdensity Sign on Non-contrast CT immediately after mechanical thrombectomy predicts parenchymal hemorrhage in patients with acute large artery occlusion. First part is the introduction. Well, everybody knows the mechanical thrombectomy has been the mainstay treatment for patients with, with ARS patients due to the large artery occlusion. But unfortunately, over 50% patients will still experience unfavorable outcome. One of the most common complications is hemorrhage transformation, especially the parenchymal hemorrhage, is closely associated with the deterioration of the neurological symptoms. Therefore, early prediction of the hemorrhage is very important for the post-interventional therapy adjustments, such as when or whether to start anti-thrombotic therapy. Nowadays, in many hospitals, immediately post-interventional non-contrast, we call it NCCT, has been introduced to estimate bleeding complications. And we found that the hyperdense lesions may frequently be detected on NCCT after procedure, but such hyperdense lesions on NCCT have not been fully understood. And the previous research reported that the possibility of the HT dependent on the different morphologic features of the interior hyperdense lesions after intra-arterial thrombolysis. And in some other previous research found that in intracerebral hyperdense lesions with a maximum Hoffman unit more than 19 was also associated with a symptomatic hemorrhage of the interarterial thrombolysis. In consideration of above, we propose the concept of the metallic hyperdensity site, combining both maximum Hoffman unit and morphologic features. Finally, the aim of our study was to evaluate the value of the metallic hyperdensity site following MT for predicting pH in 24 hours in ARS patients with large artery occlusion. This is the method. We reviewed of the prospectively collected database for consecutive patients with ARS who received MT between January 2014 and September 2018. And the second one is the NCCT examination was performed immediately after MT. And the last one is the have a follow-up CT or MR scan in 24 hours. And the exclusion criteria is the image quality was poor because of motion. Finally, a total of the 198 patients was included in the final analysis. Here's the imaging classification. First, we can see the image A. Image A shows the criteria cortical hyperdense lesions with high CT values, and the image B was the subcortical hyperdense lesions, and the CT value is not that high. And the image C is the hyperdense lesions in the area of the basal ganglia, and the image D, we can see the hyperdense lesion was also located in the basal ganglia, but the CT value is not that high as image C. And the image E showed the hyperdensity site located in the basal ganglia, but it's dot-like, and the range, the scope is very small. And the image F, we can see the hyperdensity site is not only in the basal ganglia, but also involving the both context of the subcortical area. Here is example. We can see the hyperdense lesion is located in the cortex. We can see we call the cortical hyperdense site. We can see there's there's no bleeding on 24 hours SWI after the procedures. This example of we call it the particular hyperdensity sign. It means the hyperdense lesion was located in basal ganglia, but its range very small. There's another example of the hyperdense lesion was located in basal ganglia. We called it a softer hyperdensity sign because it's hyperdense lesion. The CT value is not that high. Here's another example of the hyperdense lesion. The hyperdense lesion, it shows the hyperdense lesion is a basal ganglia with a wide range, but the CT value is very high, and the severe hemorrhage transformation could be seen on 24 hours NCCT or MSWI. Here's another example of the metallic hyperdensity sign. We also can see the hyperdense lesions is located in the basal ganglia, and the CT value is the 121 and 164, and we can see there's a severe bleeding on the NCCT or SWI at 24 hours after MT. Here is a method. So we propose the definition of the metallic hyperdensity sign based on our observation. First, there are no non-particular in intracerebral hyperdense lesion is basal ganglia. The second one is diameter is more than 1 centimeter. And the third is the maximum UCT value is more than 19 half a unit. The method of measurement, we first put our image in the radiant DICOM viewer, which is the open source software. The right side is the website. Then we manual segmentation of the hyperdense lesion on each layer. And finally, we measure the CT value of the segmentation area on each layer and recorded the maximum value. Here is the image analysis process. The number of the eligible patients is 198 patients. And among them, we see the hyperdense lesions. The hyperdensity sign was seen in 165 patients. The remaining with no hyperdensity sign. And the intracerebral hyperdense lesion was found in 155 patients, and among them, 59 patients have the metallic hyperdensity sign, and the remaining 96 patients have non-metallic hyperdensity sign. And we can see in the metallic hyperdensity sign group, 45 patients have the parenchymal hemorrhage on follow-up CT or MR scan in 24 hours. The table 1 shows the comparison of the characteristics between patients with and without metallic hyperdensity sign. We can see the patients with metallic hyperdensity sign was more likely to have the atrial fibrillation and underwent more time of the ritual attempts. And other demographic and clinical variable, including age, sex, hypertension, diabetes, baseline NIS, and the onset to punch time did not significantly differ between patients with and without metallic hyperdensity sign. And table 2 is the predictive value of the metallic hyperdensity sign for the parenchymal hemorrhage. The sensitivity, we can see the sensitivity, specificity, positive predictive value, and negative predictive value of metallic hyperdensity sign in predicting PH was 88.2 and 90.5%, and 76.3% and 95.7% respectively, and the area under the curve was the 0.894. Here's another part of the discussion. Well, first we know the brain ischemia and hypoxia lead to the blood-brain barrier damage, and because the basal ganglia is supplied by the perforating artery and the collateral circulation is poor, so the damage of the blood-brain barrier is more severe. And the second reason is the leakage of the contrast media is reflected by the hyperdensity on the NCCT, which is reflecting severe microvascular damage. And the last one, if when the hyperdensity, the metallic hyperdensity site involving the cortical area means the damaged brain tissue is more extensive. Therefore, we proposed the parenchymal hemorrhage is more easily to occur. The second part is the atrial fibrillation and the more ritual attempts means the more rapidly onset and with the poor collateral status and with wider range of these ischemic tissues means finally can lead to the BBP disruption is more severe. So finally, we think metallic hyperdensity site is caused by the leakage of the contrast into the extracellular space as a result of the microvascular damage and the increased permeability of the blood-brain barrier damage. The last part is the limitation. First, it's a single stroke center with a moderated number of cases and heterogeneity in evaluation of the pH, because we have the two methods to evaluate the pH, the NCCT and the MI, the SWI. Finally, the selection of the 30 Hoffel units was still based on the previous research. Thank you for your attention. Thank you so much.
Thank you.